Hey guys, welcome back to the Foam Frat podcast. Lots of moving and shaking going on over here in the Foam Frat salt mines. We just released our capnography workbook. So if you haven't checked that out, I'll put a link to that in the show notes to this episode. And that was the little primer before the end-tidal CO2 or the CO2 clinic in 7 days from now. And so what that is it's a very focused topic where we go in and we're just going to start extrapolating out different parts of CO2 clearance, acid base, ventilation, and it's a 3-hour course. It's $35. You can go over. I'll put a link to that in the show notes as well. But we're really excited about that. Sam, you've been pounding out these talks, and the graphics are amazing. I love the one with Homer Simpson that you just put up.
Everybody loves anything to do with some of those classic characters. If you can make a graphic out of that stuff. But yeah, it's been nice to just really focus in on one thing. Cause you and I were talking, should Foam Frat put on like a little conference or something like that? And I'm like, I do enjoy conferences, but like, and you see a couple like really good talks and you get to network with people and stuff. And I'm like, we always talked, if we did it, we'd want to do it on something really specific. And then we came up with this clinic thing where sometimes I'll attend something and it's like the topics jump around so much. I get a tiny bit of this and a tiny bit of that, but it's like my brain's more invested over here. It's like I think about only that thing and then the rest is kind of just noise. I have a hard time, like my brain has a hard time jumping around different topics and you're remembering all these, unless you're taking like really detailed notes or something. So yeah, our idea was maybe we just pick one really specific topic and we do a super deep dive on it. And that way you kind of get like the ground up approach. So I wanted to call it like the anti-con or something like that. Like it's not one of these things where you're jumping around a bunch of different topics, but you're just attending some really cool stuff and driving home that and getting good at like that one thing. And so that's kind of more our style, I think, is making sure that point is driven home. So I'm like, yeah, most people know like we haven't done something like this before. So I'm super excited for it. But yeah, next Friday, what is next? It's the 18th, right?
18th. Yep. The 18th.
In the morning. So 9 Central to 3 hours from then. So it'll go up until noon.
Yeah. And I love the idea of putting out a workbook, a couple weeks before, and then everybody gets into it. They get some questions and then we all meet together and we just hash it out. And we have topics that we're diving into. And when you're saying we're going to talk 3 hours on CO2 clearance, you got to get into the logistics and the nitty gritty.
Not all CO2 clearance, just so everybody knows.
Yeah, not just CO2 production, CO2 transport. When you're getting into a topic like that and you're going to spend a lot of time getting into the details, it forces you to really pull out some things that maybe you hadn't considered before. So
I'll tell you guys the talk titles. Yeah, I'll tell you guys the talk titles really quick. Tyler's doing, is it really the gold standard? And then I do, should I treat my patient based on their end-tidal CO2? And then what happens when your CO2 levels get really screwed up? That's where that Homer Simpson one came from. And then you're doing pressure support or not, acidosis versus alkalosis. You are also doing, they've got shunt. What does that even mean? And then I'm wrapping it up with top 10 end-tidal CO2 waveforms that impact your treatment, which I do give like a CO2 capnography talk where I go through a lot of those waveforms, and they're in the book too. But I went over and like redid all of those waveforms with like graphics that explain what's going on in the lungs. I just finished that one. So I'm super excited for people to see that because I think it'll tie it together. We'll do case reviews every hour and stuff like that. So if you guys are able to join, come on in and check it out. We're excited about it.
Awesome. All right. So I just recorded the podcast with Leon Eydelman, who is a physician. He's an intensivist down in Chicago. And I was picking his brain on implementing or the merit of having ultrasound-guided pacing to where you can actually see the heart. And that's how you are confirming that you have good mechanical capture using things like E-point septal separation to quantify that. But you probably could just eyeball it. And then you watched that episode last night. What were some of the questions that you came away with that you wanted to kind of hash out before we get into the content?
Yeah, I'll tell you one question I had and then one just point that I appreciated because I know that you felt like you guys are having more. I like the conversation style that you guys have because it was free flowing and you guys got into a couple different things. Like I liked everything that Leon was saying about, there's these very basic algorithms, but that's really the starting point for the lowest common denominator. So he'll get into that. I don't want to belabor that or anything, but that's a really cool point, because this does get into more of a nuanced. And you got to really, like, I'll tell you guys, as you listen to the podcast, you got to really pay attention to the patient selection that they're talking about. So, and I think you guys do a really good job of like defining what that very specific patient population is, and when you might be breaking from that general algorithm. So those are really cool points. But my question was, when do you see? Because you go into like, okay, so talk about that AHA guideline, bradycardia, epinephrine and pacing, like on the same kind of page here. So if you're going down this pacing route, do you ever see a time when a push dose pressor might replace that, if you had if it was equivalent in speed and things like that? Do you see a time where like you just do a little push dose pressor, like some epi to bring it up? Are you starting an infusion during this? I'm just kind of wondering, like, where does like something like epi? You did talk about norepinephrine a little bit in there, but I want to know, like, is there a place in this algorithm in your head where you do start an epi infusion or go to push dose pressors? Where does that fit into kind of this mental model?
Yeah, it's a great question. In the patient that is bradycardic and has a pulse in front of you, the AHA says that you can use chemical agents or electricity, in that they have equal benefit. And obviously, if you have an IV established, maybe increasing something or adding something like epi would help increase the native function. And if you have good communication between the atrials and the ventricles, then you can maintain that atrial kick, and that'd probably be the better way of doing it. But the patient that we were really talking about in this scenario is one that you can't feel a pulse on, but you're looking at the heart and you're like, that should equal a pulse. Like, that contractility should be generating some sort of forward flow, and you don't feel that, and the heart rate is very slow. And that's the patient that I think there could be benefit to pacing. And I will say that when I see these patients, and when I say these patients, I mean like the 2 or 3 that I've encountered, they've already gotten epi, and they're not responding to that epi because they were being treated as a cardiac arrest prior to us looking at the heart and going, hey, that's not a bradycardic PEA. That is a patient that has a bradycardia with a profound hypotension. And that's the patient I think we could pace. And in those situations, I got to believe that there's epi circulating through the heart, but maybe there's a nodal malfunction. Maybe there's some sort of denaturing of the nodal cellular connections or network that's causing it to brady down like that, especially if you see good mechanical function when it does have electricity, but it's just slow. And Leon brought up a really good point of why is that occurring and how super important that is to ask that why, instead of just trying to put Band-Aids on the circulation aspect of it. But considering all of your things that can cause bradycardia, I think of like the diet acronym where you have drugs, ischemia, electrolyte, and then I added the T for tics for Lyme's carditis, trying to consider if one of those things could be causing it. But to get back to the question of does epi have a benefit, I think it does. But if they've already gotten epi and they're still bradycardic, I think it's time to try something else.
Yeah, I think there could be a transition point too. So I'd like, the one point that I would like, my mental model would add is like, if that presenting bradycardic rhythm had agreement between the atrium and the ventricle. So, this was like a really bad sinus bradycardia, or they had a first degree, or even like a second degree type 1 or something. If the heart has the ability to coordinate the atrial kick with the ventricle, I would always have like in the back of my mind, I wonder if I can get back to that. Maybe the pacing is needed in this temporary emergency scenario where we need to get, maybe it's the coronary perfusion pressure that has to get up, and that's why it's not responding to epinephrine, or whatever the case is. If you start to have a sustainable blood pressure and you feel like the diastolic is starting to fill those coronary arteries and things are improving, you start to wonder, do I have to keep pacing this? Because when I do pace, like transthoracic pacing is an amazing thing, but I am also losing that atrial kick, where that could account for, 20 to, some references will say like 30% of my cardiac output if I don't have this atrial kick to stretch my ventricles out and stuff, like we talked about not that long ago with the Starling's curve and all that kind of stuff. And so I'd always be thinking in the back of my head, if I saw initially that there was agreement, I'd be thinking, I wonder if after pacing for a while, if I could get back to that thing. Like, I wonder if I could, wean off the pacing and start the epinephrine where it, increases the native heart rate, and then, my demand pacer turns off or something like that. That's kind of where I was thinking with that. If there was agreement, can I get back to that agreement? Because that's going to be the best way the heart's working.
Yeah, that's a great point. And that's a really good point when it comes to deciding, a sinus bradycardia that is profoundly hypotensive.
Mm.
There's got to be a way. I always think there's got to be a way of reversing that. Like something is causing that node to just, and it could be something like sick sinus syndrome. It could be tachybrady syndrome. And there's also something called the Bazol-Gerish reflex that can occur when patients are having an MI, and that responds really well to atropine. And I don't think we should throw the baby out with the bathwater when it comes to atropine in these. And, I feel like they now recommend atropine in a PEA bradycardic rhythm now, but I could be completely off. But somebody told me they were bringing atropine back. And so that's an
Higher
interesting.
dose, yeah.
What's that? You've heard that too?
Higher dose, yeah.
Yeah, higher dose. And so I think there's a lot of nuances to an arrest situation, or what we call an arrest. And we're finding all these specific patient populations, as we talk about in the podcast, that maybe benefit from things outside of the box of standard ACLS. So I think you guys are going to really like this episode. Leon is a super smart dude, but he's just like so down to earth. It's so cool. Like I'm sitting here talking to this dude thinking like, this guy is a board certified intensivist. He's doing ECMO stuff down in Chicago, but you would never know it. He's so humble, and he's just a great asset to the Foam Frat team. So I think you guys are going to really like this episode. Should we roll it?
Let's roll it.
I put out a blog yesterday.
Yeah.
And you looked over it, and we talked about ultrasounds, merit in pacing. You got a patient who you're trying to make sure you get mechanical capture. And, it's probably really good to look at the heart and actually see the heart beating, as opposed to, trying to palpate a pulse, or maybe you're using pulse ox, which is great, but you can have a patient with a pulse that just has a poor pulse ox reading as well. And so I really think that there's a strong implementation benefit of having ultrasound when you're pacing. But I kind of brought up a different subset of patient. And this really was sparked by a couple of encounters I had with patients where they had a bradycardic rhythm. Nobody could feel a pulse, but I could see a pulse on ultrasound, or I could see the heart was contracting. And instead of treating that like a cardiac arrest, we went down the pacing route and then turned up the milliamps until we saw we had capture. What was your thought after reading that blog? Was there any questions you had, or any concerns, or does that mimic things that you've seen in your experience as well?
Yeah, I mean, I think it gets back to some of the conversations you and I have had, and not that this is just kind of our idea, but this concept that PEA is a really weird concept. Like if you have this electrical activity, what really is the difference between bradycardia and PEA? And I think it really is if the heart's ejecting or not, right? If what we're after is, do we have a pulse or not? That's very like 1800s, right? Like you put a finger on the carotid, can you feel it? Well, they've been doing that probably before 1800s, right? So it's just weird that we keep that as our paradigm as we've advanced into having much better techniques of evaluating and understanding perfusion, which is really kind of what we're interested in as opposed to pulse. Because especially gloves on, heat of battle, like I can't feel anything. I'm like, do I feel it? I don't know. They're looking up at me, doc, do you have a pulse? I'm like, I'm not sure. I don't know. And so the ultrasound approach is definitely the best way of doing that. And if the question is there a pulse? I think that means are you seeing the aortic valve open? And if you are on ultrasound, then for whatever that's worth, which I'm not necessarily sure what it's worth, but like you have a pulse. That's for sure. So if you're going to use kind of as ACLS says to do, if you're going to use presence of a pulse to be your distinction point between like profound bradycardia versus a bradycardic electric rhythm in PEA, then that's absolutely what we should be doing. And I think using the ultrasound is going to pick up a lot of people that are PEA and are actually bradycardic with a heart that's ejecting, probably softly. but sometimes not, right? Sometimes just from how slow it is, you're not getting a good pulse, and you put the probe on, and the heart's squeezing just fine. It's just really slow.
Yeah, that's interesting because the majority of the cases, and I say the majority, I've only had probably 2 or 3 cases where this has occurred. The patient was being treated as a cardiac arrest prior to us putting the probe on and looking at the heart and being like, hey, we have a heart rate of 25, and those contractions, when it does beat that 25 times a minute, look pretty good. And so that starts to make my head go down the nodal ischemia, nodal problems, as opposed to like an actual mechanical problem. And I think that's a very different patient than the patient that is in VFib arrest and then deteriorates into asystole. And so when I was looking at why AHA took pacing asystole out of the guidelines in 2005, there was like 2 or 3 studies where they looked at it. A couple of them were actually pre-hospital, but they had a lot of limitations to those studies. And they looked at all comers. So even if a patient went from VFib or VTAC and terminated into asystole, they included those patients. They didn't have any way of actually confirming that they had mechanical capture. So they were just turning up the milliamps until they saw a pacer spike followed by a wide complex. And so I don't think you can throw the baby out with the bathwater and say that we should absolutely not pace a patient that is, and I'm not going to say asystole because I'm not on board with pacing asystole, but sometimes those lines get really blurred when the heart rate is really low. I mean, I think you and I have both seen a patient that has an agonal beat, maybe 5 times a minute, and it's flickering. And, are you going to say that that patient's a profound bradycardia? Well, if I see that patient go from a 3rd-degree block into a Brady rhythm, and they Brady down from 30 to 10 and to 5, like, I feel like that's okay to pace. Whereas I think a lot of people want to go and start CPR on that. But if it deteriorates from like VFib and then it goes into that, that's a different patient. And if I don't see that, I have to assume that they were probably in a shockable rhythm and it deteriorated if I didn't actually see that progression in front of my eyes. But I'm okay with a patient who's got a heart rate of 20 that they're treating like a cardiac arrest because they can't feel a pulse. If I look at the heart and I see that it's contracting, I don't think there's anything wrong with trying to pace that. And like you said, if you're seeing the mitral valve, hit the septum, you're seeing that aortic valve open, you have forward flow. And at that point, just looking to see if you can find a pulse on ultrasound. And if you can, you're going to see a pulse way before you actually feel one. What do you think of that mindset?
I mean, I think that's absolutely the right approach to this. The ultrasound is what makes a difference for it, right? So if you are seeing adequate cardiac function, if you are seeing, that mitral valve moving at least halfway decently, it doesn't have to slap the septum, but if it's doing something, then you can see that, the output you're getting, the mechanical beats are doing something. It's, in my experience, in my world, a lot of our cardiac arrests are, it's 6 a.m. and, no one's seen the patient in 2 hours in the hospital, and, they walk in and the guy's dead. And so, you call the code, everyone runs in, you put the pads on, asystole. Yeah, I mean, that's, asystole. And maybe you might have an electrical escape rhythm every now and then. And if we do put the ultrasound on, maybe we do see a real weak, little attempt at squeezing. But those patients are, profoundly probably acidotic. They got other electrolyte issues, and they've already been, pickled, for lack of a better word. They've been sitting there. So I think pacing that is going to be unlikely to work, because the issue isn't really, lack of nodal firing. It's going to be like an overall acidosis, pH problem, electrolyte issues, which are impacting both your electrical pacemaker as well as the ability of the myocytes to respond to those electrical signals. The case you're describing, where you put a probe on and you see the heart doing well, just really bradycardic. I mean, it makes you question why, like, what's going on? Because, outside of like a true 3rd-degree heart block, it's difficult for me to necessarily imagine what kind of patient has that going on. A bradycardia, but yet like a heart that actually responds well to electrical signal when it gets it. I think some kind of nodal blocking overdoses would fit this perfectly. But otherwise, and it could be because we don't have this data, right? We go off what AHA says, we go off what ACLS is, and we can pretend that that's driven by evidence. But I mean, like, come on, like it's not actual evidence. It's impossible to prove much benefit in this kind of a patient population, and we can keep having these pragmatic trials over and over again with thousands of people, and we're going to keep wondering, should we intubate or not? Should we give epi or not? And it's just hard to get true data, and so I think there's nothing more powerful than seeing the heart squeeze well, but pretty slow, and that would intrigue me, and absolutely, that would get me starting a pace. The question I'd have at that point is, are you actually in cardiac arrest? Are you actually profoundly malperfusing? And if the issue is it's hard to get a pulse, maybe that means it's hard to get a blood pressure. And at that point, I'm really curious to know what the end-tidal capnography is. I mean, exactly how much are these 15, 20 beats doing for the patient if the heart is squeezing well? I had a case just a few days ago. We had a patient, rapid response from the floor, kind of a similar situation, was okay an hour ago, and then now is not. Bradycardic, hypotensive, unresponsive. Tubed him, put the probe on. He's beating at about 40 beats a minute. So like, well, is that enough? Is that not enough? And we tried to pace. I tried to pace at that point. He was hypotensive, Brady enough for me. And it didn't capture at all. And that's about the point where, we're going all the way up. And they're just like, man, he's freezing cold. Oh, wait, his temperature is 28 degrees. So it's those kind of things, which is the reason why the native pacemaker isn't working. And the same reason kind of is why the heart wasn't responding to electrical signal anyway. If you're seeing legit contractions on the ultrasound, I think it's definitely worth trying to pace and treating it as a symptomatic bradycardia. I mean, that's what it is. That's what it is at that point.
Yeah, you just brought up some really interesting points, and I'm glad you got to figuring out why that patient is bradycardic, because that's super important. And I've seen patients who get paced all the ways to the hospital who have a potassium of 8.4 when they have a history of renal failure, they're on spironolactone, like they got the whole story. They missed dialysis or whatever, and somebody was trying to pace them, and usually it's unsuccessful too. It's really hard to pace a heart that's hyperkalemic. And instead of just giving them some calcium and trialing that out. And so it is important to think about the why. And you're right, like a patient who is profoundly bradycardic but has decent contractions when it does beat is probably not super common. That's probably a very specific subset of patients, but it's a subset that I've seen a few times. And, usually it is in the case of a toxin, an overdose or something. Patient takes a bunch of their pills and you don't know what they took. And in that immediate phase, if you don't feel a pulse, you're thinking, all right, we got to get on that chest right away. We got to start doing it. This is PEA and they're bradycardic and we got to start doing chest compressions. And I don't think there's anything wrong with that, but I do wonder if you can see the heart is beating, doing asynchronous chest compressions on top of that, is that providing any benefit? And in your case, when we were talking about that, you said, this patient had a heart rate of 40, but when I looked at the actual heart, it was just not ejecting very well. It was poor ejection. And that's probably a patient where you would say, hey, even though they have a heartbeat, like they're not ejecting blood out of it. And I see a little bit of twitching going on. Maybe we should start CPR. Let's get the Lucas going. And I think that's really interesting because that's a case where you have a heart rate, it's moving, you have echocardiographic motion, but you're saying I'm eyeballing this and that is not an adequate contraction. Let's get on and start doing chest compressions. Whereas the one that I had seen, it was slow but beating appropriately. And we start turning up the milliamps and start increasing the milliamps. And then, and sometimes I have to change pad placement a little bit. I like to go anterior, posterior. I think that's what you're doing as well. Just kind of sandwiching the heart on the left side. Start going up and you're actually like eyeballing it. And once you see that you have left ventricular contraction. And I talk about looking at like E-point septal separation if you're really wanting to like quantify that. But you could probably just eyeball it. I think that's what a lot of us are doing, is just eyeballing those pressure differentiations. And you turn it up and you go, wow, that looks like they should have a pulse. And if that point they don't have a pulse, well, especially if it's something like an overdose, you could have just vasoplegia. You could have systemic vasodilation. And it was really interesting because a case I had a while back, we started doing this, we started pacing, and the physician's like, I don't feel a pulse. There's no pleth wave, but we can see the heart is beating. We see that aortic valve opening. So I switched to a linear probe just because it was a little easier to actually see the vessel. And I threw it on, put Doppler on it, and you could see that there was a pulse, but you just could not feel that pulse. It wasn't enough to actually palpate it. And we know what the studies say about us trying to find a pulse. Well, so we start Levophed at like 5-10 mics a minute. And then within a few minutes, boop, you see the pleth wave come back. And so how long would that patient have gone in cardiac arrest algorithm, and then would they have had the same success as if we just started pacing and then started running pressors? And that's the area that I'm like, you know what? I'm probably going to get eaten alive for saying like, hey, if you don't feel a pulse, maybe we should pace instead of doing CPR. But I do think that there's a subset of patients that would benefit from that. And I've seen it, but it's confirmation bias. There's really no study showing this. But like you said, how do you study that? Like, how do you take a very specific patient? And I think about like when you talk about very specific patients, I think of like Demetrius Yiannopoulos and Jason Bartos, who are like, okay, most people, if they're in a VFib rhythm and they survive, they get shocked like the first, second, or third time they come back. Like that's the majority of those patients that survive. And then you have this like subset of patients that are in refractory VFib and they're getting shocked multiple times. And those are typically patients that will just deteriorate into asystole and end up dying right there on their living room floor or whatever. And those patients are a very specific subset that will respond to ECMO. We have, really good evidence with the ARREST trial that if we can do good CPR and oxygenate properly and get those patients to an ECMO capable facility, they do really well. Sometimes even after having CPR for like over an hour, they still do decent. And they do really well. And so I think the more nuance we can get with our idea of what cardiac arrest is, and we can find these subsets, these little clusters of patients, instead of putting everybody into this big, bowl that says cardiac arrest, we're going to start seeing more benefit. That's just my hypothesis on it, is we're going to find nuances. Okay, the VFib comes back after the first, first or third shock, first, second, or third shock. Then you got these patients who probably benefit from ECMO. Then you got the patient that Brady's down into asystole, or Brady's down into a really, really low heart rate and you don't feel a pulse, so they may benefit from pacing. Am I crazy,
Yeah.
Leon?
No, I mean, you're not crazy at all. This is the issue with like protocolization of really anything in medicine. And I think, my experience with this controversy was about kind of sepsis, early goal-directed therapy, the wonderful outcomes that we had from Manny Rivers' trial from early goal-directed therapy, and then the just like ridiculous protocolization that spawned like 10 years later when the government caught up to the science. Of course, by then, several studies were showing us that protocolization isn't it. Not my quote, but you don't have to do a lot of shit. You just have to give a shit, right?
Mm-hmm.
So it really, it's frustrating when sometimes people are dead, right? Especially again in my world, this is like in hospital arrest, like these people are found dead. They're dead. There's nothing you can do about that. I think most of the time when you're seeing folks, they're warmer. They're at home. They're normal people. They're not sick already. They have people checking in on them. So likely there's more of a chance that they're physiologically salvageable. And that's why cooling really has no real evidence in hospital. But if we're not going to be nuanced, if we're just going to follow this ECLS protocol, I mean, how are we any different than, and not to put this down, but like the Walgreens Minute Clinic or the casinos like in Las Vegas, they get great outcomes just following regular ECLS, right? Because of early detection of arrests because of all the cameras. So like there's a role for that. And that role is in the untrained provider's hands. when we've got people that are discussing this sort of stuff, like, no, we don't need to be giving epi every 3 to 5 minutes just because we don't feel a pulse. Put the probe on. Check your end tidal. I mean, there's lots of harm to some of these interventions too. So I really think that we have to be nuanced about this, or we're not doing our patients any favors, and we're not utilizing our training and our skill set to its utmost. It's like before cardiac arrest, at that crashing patient, boy, we're going through every differential. We're thinking to do everything, and then as soon as we can't feel a pulse, oh, that's it. Epi 3 to 5 minutes, shockable rhythm. Is that shockable? No. Well, then you can't do it. Is that asystole? Oh, you can't pace that. It's all about kind of being present and actually following up on what's going on. And absolutely, I would attempt to pace. And, from my perspective, if that's what I'm seeing and I'm getting an end tidal that's halfway decent, then I'm just cranking up the inotropes at that point. And I've got a lot of people around. I got nurses to kind of help do all this. And I've got a million hands. And I'm just, calling out orders. But, pacing would make a lot of sense. I think in hospital, we're probably a little less comfortable with pacing than, critical care out of hospital providers, because we have less of these folks who have arrested because of salvageable issues, likely ischemia, like we're talking about, or third degree heart block. I think we're less comfortable with that. We don't jump on that quite as quickly. I think we should. I think we should try it more often. And in particular, if we're seeing a heart that's beating well, but really slowly, we got to ask why. What's going on? Because this is certainly seemingly a salvageable patient versus, same thing, asystole, 10 escape beats on the monitor, whatever it is. You put the probe on, there's nothing going on. Well, all right, now you've got electrical activity, but nothing else. And that completely changes the context. And it changes how aggressively we respond and how long we keep going. So I think there's room here to be less kind of arrest and rhythm focused in our resuscitations, and more room for perfusion based. Like, whatever's going on with this patient, is it enough? Can you feel a pulse? No. All right, but is the end tidal 30? Fine. Then maybe they had a stroke. Maybe that's why they're completely unresponsive. I mean, that could certainly be the situation. So I think we really ought to be focusing more on how do we improve this patient's perfusion. If it's bradycardia, crank up the pacing. Let's get that done. But this pulse concept being our driving point of what we're doing next seems a little outdated to me.
All right, so I'm gonna walk through a case now, and I want you to tell me where this would fit into your routine. So let's say you and I are flying together. We go in. We have a patient that came in asystole, and their family members think that they possibly overdosed on something. The BLS crew tells you that they have not had any shockable rhythms. And so they're telling you it's asystole, but you look and you see that the patient does have, like, we'll say a heart rate of like 25, 30. So they're doing CPR currently. They stop the CPR for the rhythm check, and you see just like a couple little solitary beats going through. You have your ultrasound probe. We'll say you're subxiphoid right now, and you look and you see that the heart's actually beating. And they say, all right, 10 seconds is up, or 10 seconds. Let's start CPR again. So they start CPR again, get the Lucas going. And you could see that the patient did have contractions of the heart, but nobody felt a pulse during those. What are you saying to the crew to say, hey, we should stop CPR and try pacing this? Or what's your next step in that?
Yeah, I think if I'm seeing that, the first thing that comes to mind is, make sure you push the other stuff, the bicarb and the calcium, the other stuff like that. Because now we are wondering, is this a metabolic issue? Like you were saying, is it hyperkalemia? That'd be my first thought of seeing that rhythm. Pacing doesn't jump out at me immediately just because I've done it less often. But honestly, after speaking with you and after kind of trialing that a few shifts ago, it makes a lot of sense to try that. I'm not sure that I'm turning off the Lucas while I'm doing that. My thought is, again, I'm focusing on perfusion. Maybe we're intubated, maybe we're bagging, whatever it is, we're checking end tidals. And if I'm at an appropriate spot with the Lucas, like that's my first go-to. Get to where we need to get. Because it's pacing, right? With the Lucas, I've got that heart rate already. And then at that point, I would say, all right, man, that's pretty weird. Like at every single pulse check, we got a few of these good beats. Great. Let's start cranking up the pacing. We pushed our other meds. Let's start cranking up the pacing. And I would say I'm doing that with the Lucas on board, and then pausing. Maybe not waiting a full 2 minutes if I really think there's something good there, but pausing it and seeing, do we have capture? What's going on with this? If not, turn it all the way up, keep going, turn the Lucas right back on, let it pause for a minute or two, and see where we're at. And see if those meds have had time to work too at that point. And if that's what I'm seeing, I'm probably yelling for someone to come, if, maybe me, maybe a resident, whoever it is, to get a blood gas, because at that point, this is something pretty salvageable potentially. And I really want to make sure I'm not missing a pretty simple, electrolyte issue. But I probably got the Lucas on board, and yeah, let's crank up the milliamps. Let's see if we can capture, and let's pause that Lucas to see where we get.
Yeah, that's really interesting to me. I love what you said about the end tidal CO2 earlier, because that's important. Because if your end tidal looks like garbage and you're looking at the heart and you're like, oh, that looks like it should be contracting appropriately. I mean, albeit you could have some VQ mismatch within the lungs that's causing, let's just say they had aspirated or whatever, and so you're not getting a true end tidal CO2 value. But all things being equal, I think the positive predictive value of seeing that and saying that this patient has good perfusion is probably pretty high. And if you are pacing at the same time that you're doing chest compressions, what would you say the benefit of pacing is at that point?
I'd say there isn't much benefit at all during that point, but I'd say I would want to get that going already, so that when I pause, that's not when I'm cranking up the milliamps. What I want to do is when I pause the Lucas, because I'm trying to minimize the amount of time that we're not perfusing. So if we got where we need with the Lucas, or with hands-on CPR, I don't work for them, not yet. But if we've gotten where we need with that, if we have, then I'm a little loath to stop doing the thing that's gotten us to where we want to be. And so that's why I kind of start those other processes while we have that. And then I'm pausing the CPR and pausing the mechanical device and seeing where we are with that. But the role of them in conjunction would be, I don't really want to wait and see if it works. I want to keep going with the thing that's working. When I'm pausing it, we're already on, high amounts of milliamps. Hopefully we're capturing. We take our 5, 10, maybe 20 seconds at that point to really try to figure it out. But otherwise, because the next step from our perspective is getting a transvenous pacemaker floated in, if that's what it is. And that's tough to do with the Lucas ongoing, but it's not impossible. And so if you're getting what you need with that, then I'm favoring that over anything else. But I think the pacing ought to get started before, turn off and see where we get, especially if, it certainly adds a risk of RNT and maybe devolving into something else. And certainly there might be some patients harmed by that. But typically, my mantra is, if we're getting where we need with this mechanical compression, great. Let's get the hell out of there. Let's get to the ICU. Let's get to where I can get my monitoring. Let's get an A-line in. Let's get all that stuff going. Because I'll take the downside of prolonged CPR to the downside of even a minute of less perfusion than what I could have gotten with it.
In those studies where they looked at pacing asystole, they did that exact same thing. They had chest compressions going while they were pacing. Makes sense, because of what you just said. When I first read it, I was like, I don't understand the benefit of pacing, trying to make the heart contract if you're actually manually pumping it. And when you look at some of the neonatal literature that looks at asynchronous chest compressions, when you have a native heartbeat, but it's less than 60, and so you start providing artificial chest, or not artificial chest compression, but artificial beats with chest compressions on top of that, the coronary perfusion pressure actually goes down, because when you have a low pressure within that aorta and you push on the heart, you can have retrograde coronary flow out of the coronary arteries and actually steal blood from the coronary. So I was wondering, you got a patient that's got a heart rate of 20, 30 or whatever, and maybe that you don't feel a pulse, but you're seeing decent contractions. At that point, if doing those chest compressions could create that same situation, because we know our diastolic's low, and the diastolic pressure is what's feeding those coronary arteries. And so if you have a low diastolic pressure, you're pushing on the heart. Are you ever going to build up enough of a coronary perfusion pressure in that milieu? And I don't know what the answer to
Yeah,
that
no,
is.
you're absolutely right. I don't think you would. But then on the other hand, if your issue is not enough, coronary perfusion pressure, I'm wondering if your presentation is going to be this sort of hypersymptomatic bradycardia at that point. It certainly could be, right? I mean, why not? Like a focal ischemia could certainly give you a heart block or this kind of a profound bradycardia with pulselessness, at least palpation by fingertip. So it could be, but I think at the point where we don't know, I think I'm probably erring on the side of using the Lucas device or whatever, continuing with CPR, turning on the pacer, and then holding. I mean, you're definitely right. It might, in fact, work against you. But then again, you're pausing after 2 minutes, and if you are seeing capture there, if you are seeing good rhythm, great. I think you've stopped. But you bring up a very good point that I'm trying to have my cake and eat it too, and that gets to how hard it is to be finesse, to be with ACLS or with cardiac arrest care. It's hard to do that, and so it really takes a lot of thoughtfulness and a lot of really second by second thinking and managing and watching what you're seeing on the ultrasound as you're pausing your Lucas or asking for hands off the chest, because it's you could definitely see the downside to that.
Oh God, yeah, absolutely.
But hopefully after just a few minutes, you might see the pacing actually kicking in. So
And I'm trying to relate this to neonatal literature, but there's some nuances to that, and like most of these cases, the patient has a patent ductus arteriosus, which could cause you to have a harder time getting your pressures back, your or increasing systemic vascular resistance. And usually if you're doing chest compressions, you're doing things like epi as well. And you are shuttling blood from the right side to the left side, hopefully at a fast enough rate, or I should say fast enough, but at a good enough rate that you start to rebuild that diastolic pressure. And the epi on top of that, I don't know if you would still have that issue, but it was just something that popped in my head when you were saying it. But that's probably, I don't know how well that extrapolates over to adults. I do a talk called Compressions on a Beating Heart. And we look at the literature on doing chest compressions on neonates, and essentially, like, there's no good evidence that that's a good idea. Like, obviously, if their heart rate's 10, then it makes sense to do it. But like in the patient that goes from like, they're born, they have respiratory distress, and the heart rate goes to like 60, and we start doing chest compressions, that can actually compete with ventilation, which is probably what the kid needs in the first place, is ventilation. And so it was interesting because of the pig data, you could see that they had retrograde coronary flow with those chest compressions. But I don't know. I would say that you'd have to have some profound vasoplegia, because most people, by the time I get there, have given a truckload of epi. And so that systemic vascular resistance is probably high enough to prevent that retrograde coronary flow.
And you bring up a point too about like, okay, if we're trying to maximize coronary perfusion pressure, then that means that we're trying to maximize our chances of restarting, spontaneous circulation, right? But on the other hand, and plenty of times, in my critical care patients, what the heart wants is not what the rest of the body wants. And acute ischemia MI with cardiogenic shock, dobutamine. Yeah, it's going to make the heart beat a little stronger. That'll probably help the kidneys. It'll help the brain. It's going to worsen oxygen demand. It's going to hurt the heart. Mm-hmm. So it really gets into kind of like, what are our goals in cardiac arrest care? And I think we focus a lot on this coronary perfusion pressure, and we focus a lot on cerebral perfusion too, of course, and that's probably the real money point there. But plenty of times, if we're favoring better coronary perfusion, we're not going to, the cost of that is going to be worsened forward flow. And so it makes you wonder, if it's someone viable enough that could get to ECMO, that could go to PCI, that could get an Impella, that's an overdose. It's going to get better in a few days, potentially. Maybe they can get through with mechanical assist devices favoring the end organs at the expense of the heart at that point. We're not trying to get the heart restarted. We're trying to maintain adequate perfusion to the rest of the body. I mean, including the heart, of course, but sometimes those goals might be in competition. And, and so I think it really is less about getting back to return of circulation. Oh, we feel a pulse. Great. Yeah. High five. But that's not really that relevant. The relevant thing is, how's the brain perfusing? How's the rest of the body perfusing? Because you don't need a heartbeat to have you don't need a heartbeat to be alive, right? Not anymore. Not in 2021. So it adds a lot of layers to like, what are our goals here and what are we actually trying to achieve? And I've got to say that, when I'm doing this, I'm not that interested in necessarily getting back to native function. I'm more interested in making sure that there's some degree of baseline cardiac output that's getting to the rest of the body, and favoring that over anything else at that point. And that's why, I'm pretty comfortable just leaving the Lucas on, not even checking a pulse, and just whisking them off to the ICU at that point. We are where we need to be. We've got the perfusion pressure. We've got the end tidal. Maybe we have an A line in that's shown us a good pulse, a good pressure. Great. We're in business. And then we can call cards. Then we can start putting stuff in the groin. Then we can think about going on extracorporeal support. But the heart is a lot less sensitive than the brain to this kind of ischemia. And I mean, so often, so often we get these terrible cases where, great, we got the heart back and we dialyzed through the kidney injury and now the kidneys are working and everything's working great, except that the patient's brain is cooked and they're never going to move again. And so we've gotten to a point where we're much better at protecting and at supporting and at like supplementing and replacing all the other organs, but not the brain.
No, that makes a lot of sense. Well, dude, thanks so much for chatting with me and letting me ramble. I feel like this episode is really just you and I rambling about a bunch of stuff, and maybe there's something in there that we tease out or talk about as far as pacing goes. But you definitely brought up some points that I hadn't considered before, and I think that that's what this is all about, is brainstorming. And I always love picking you and Cynthia Griffin's brains on stuff. You guys have been an awesome contribution to the Foam Frat team. So any closing thoughts, man?
Yeah, I mean, really, I've been saying this to you since we met, years ago at that EMS World Expo. It's really awesome to hear kind of providers, professionals being professionals. And yeah, you're right. This isn't, that much about ultrasound guided pacing, but I think the theme is like, use your brain, like use what you know, try to find solutions to the problem at hand. And there's no reason to be constrained by, algorithms that are written for the lowest common denominator. If you're working towards the lowest common denominator, you're going to get the lowest outcome. So we've got to have the freedom to use our minds in good faith and try to do things that work and not be constrained by, people looking at your ID badge and who are you? Oh, well, we're supposed to be following, look, we got the protocol written on the board. We've got to move past that. I know it's easy for me to say kind of my position, probably easier than folks that have medical direction and things like that. But
yeah, screw protocol. You know what?
So
we just need to all be doctors, man.
There you go. It's and frankly, I know plenty of docs who probably shouldn't be in that role of kind of leading the team because they're not doing things in good faith. They're just going through an algorithm and a checklist, and that's what pisses me off more than anything with residents. I mean, it's fine if you don't know what the hell's going on, but you should at least try. You should care. You should use your brain about this and really in good faith try to do its best for the patient, not get through the situation by going down your ACLS algorithm until you finally pronounce the patient. So appreciate it as always, man. Thank you for your input, and talking with you always adds a few layers to my medical decision making back in the hospital too.
Thanks, brother. Take care, man.